Thank you for having me, and congratulations with a great success already, because I really like it. This patient needs a tube. It's a simple question, very simple question. But do we have an easy answer? If you look in the literature, you can do a PubMed search, you will find guidelines. Emergency tracheal intubation immediately following traumatic injury. And it's clearly stated there's only 6 indications: airway obstruction, hyperventilation, severe hypoxemia, despite supplemental oxygen, severe cognitive impairment when Glasgow Coma scale is lower than 8, a cardiac arrest, or severe hemorrhagic shock. I think all trauma surgeons can leave the room now. Your talk has ended. All others can stay with me and look a bit closer. Because why would we intubate Luke Smith? Maybe because he has a coma scale of 6 or 5, or his vital parameters may be unstable. If we need to transport him to another center, he may need a tube. He may be agitated, or if you want to make a CT scan and he should lay still, patient movement is minimized with intubation, or we want to prevent aspiration. All very good indications for intubation. But let me take you to a famous Dutch artist, Maurits Escher. It's a very funny chap, I think. Here he is. And look at this drawing very closely. Do you really see what you see? It's fascinating, isn't it? Look closely. Do you really see what you see? You have to look twice. And I've called this talk Escher's intubation dilemma. Does this patient really need a tube in the emergency room? It's a simple question, and personally I find it a really, really difficult answer. Maybe this is the most difficult talk today, because some things seem very clear, but if you look carefully, you have to think twice. Okay, Luke has a CT scan made, and you see a midline shift, a subdural hematoma, and Glasgow Coma scale is 8. And if you look at the guidelines, you are happy to intubate him. But what if Glasgow's Coma scale is 7 or 9? Or saturation is 30% or 99%? Does it make a difference? If the blood pressure is low or very high? Or if he's young or very, very old, he's 95, what do you do? And another important point, if he has a difficult airway, I would rather say a complex advanced airway, are we still going to intubate Mr. Smith? This is all very context sensitive, of course, and it is always a team decision. What if he fell down the stairs and he had a ventricular fibrillation, cardiac arrest, was shocked by the ambulance, came into your emergency room with a laryngeal mask airway, has a Glasgow Coma scale of 9? Does this patient need a tube? Are you going to the cath lab? Is there respiration risk? Is he waking up? Are you going to the ICU for a hypothermia protocol? It is very context sensitive. Let me help you. It is difficult, but we can use a stepwise approach. First, rapidly assess the need for intubation and the urgency of the situation. You can do it very quickly. Secondly, determine the best method of airway management with your team. And third, construct a plan B in the event that the primary method is unsuccessful. And think of a rescue technique. Your rescue technique is not your plan B. The aim of a plan B is to put the tube in the trachea. A rescue technique is aimed to save a life. Okay, let's look a bit closer. How do we rapidly assess the need for intubation? 3 points, easy to remember. Is there a failure of airway maintenance or protection? Secondly, is there a failure of ventilation or oxygenation? And 3, very important as well, what is the anticipated clinical course? These 3 points are really important in the emergency room. Is there a failure of airway maintenance or protection? How do we check this? If you're an ED physician or an anesthetist called to the shock room, you should look for signs of airway obstruction. Check the airway. Is the patient able or unable to swallow secretions because of obstruction? Is there a stridor, dyspnea, or aspiration? And we should check ventilation and oxygenation. You can do it in the way you want, but easiest is look for gas exchange, and the gas exchange must be adequate to sustain vital organ function. Use a stethoscope, auscultate the lungs, find signs of hypoxemia or hypercapnia. And third, what is the anticipated clinical course? This is a very important question in the emergency room. What do I mean? These are the patients whose conditions are predicted to deteriorate within the next 30 or 60 minutes. For example, if you have a patient with a massive pelvic bleeding, this will not stop. You will need a tube. Or consider a patient who presents with a step wound to the neck. If there's a large expanding hematoma to the anterior side of the neck, you may expect that this is going to cause an airway obstruction. So this is important information. Step 2 and 3, determine the best airway management method and a plan B, but also your airway rescue technique. And you may be the best beaver in the forest, you may not have your lucky day, and you maybe have problems with plan A. But again, Escher has an intubation dilemma. Does this patient really need a tube in the emergency room? An important question, because are we going to intubate the patients in an environment you're probably not used to work in, or are you going to the operating room or to the ICU? And this is also a team decision. Maybe the answer is yes, the patient needs a tube, but it may be very wise to rush to the operating room where the neurosurgeon is waiting and can open the brain. And if you intubate in the operating room, maybe the situation is more controlled. It's always a balance between benefit and complications. Remember that intubations in the emergency room has a high risk at complications. We know that from clinical experience, and this is of course because of the comorbidity of the patients. It depends on the skills of the intubator and the teams, but also we have data from NAP4, a UK-wide prospective airway complication study, and they found that severe airway management complications can occur in the emergency rooms, and the outcome may be grave. Patients can die or have neurologic damage because of things that go wrong during airway management. And this is one of the most important things, time pressure. This is what makes our work really difficult. And airway management in difficult patients or during stress situations is a great example of a highly complex task. It is stressful, we have to save a life, it is a team performance. We work with specialists, but also nurses. There are pre-hospital people in the same room when the patient arrives. You have to perform a technical task in combination with communication. And sometimes in large hospitals, people don't know each other. So there's ad hoc teams, and we don't know each other's names. This is a great picture, look at it carefully, of a woman who was resuscitated in my hospital several years ago. And look at all the hands. And all the 10 people outside this picture are not visible in the screen. What you can see is an ultrasound probe. We see a manuette. We see a needle in the anterior neck. We see so many people doing one thing to save a life. It is really highly complex. It's teamwork combined with technical skills and non-technical skills. A great example of how we work during stressful situations in Amsterdam, in London, in India, wherever we do our job. And this is what time pressure does with our brains. There's no time to think. Human factors as fatigue and stress come into play. We don't have time to call for help. And we cannot even think about alternative techniques. And if I ask you to give me an answer in 10 seconds, how much is 112 times 16? Please give me an answer within 10 seconds. How much is this? This is the correct sugammadex dose, which is used to antagonate rocuronium dose if you cannot intubate and have to reverse the muscle paralysis. So this is what time pressure does with your brain. It's a very easy calculation, but nobody gave me an answer within 10 or 15 seconds. It's too complicated. Look at these saturation curves. If you pre-oxygenate a patient with 100% oxygen, and these are old studies, and you do nothing for 10 minutes, you can see on the first graph that it takes 10 minutes to desaturate from 100 to 60% in a normal, healthy guy like me. But if you're a baby, or if you're very obese, or if you're very sick, the desaturation time from 100 to 60 or 90 to 60 may be very fast. You may not even have 1 minute time. 10 minutes is a long time during stress. And I will tell you a secret. Nobody looks really carefully at these graphs, and Professor Tim Cook from Bath said to me, if you look carefully at all these graphs, then there is a turning point at the saturation of 80%. If you look at all these 4 difficult graphs, the time to desaturate from 80 to 60% for all patients, sick, young, or very healthy, is only 30 to 35 seconds. So if you ask me which situation I'm getting really nervous, I would say don't go below the 80%. If it goes down and you cannot oxygenate, your patient will really desaturate really fast. I've called this the airway danger zone. And try to win time. Important during teamwork, don't rush. Think about time. 10 minutes may be a long time. Use clear communication, leadership, and anticipate. Remember, this is also one of your take-home messages. 10 minutes is a long time. What can we do in 10 minutes? We can meditate, pick up the phone. If you call your mother-in-law and you have to call 10 minutes on the phone, it's endlessly, isn't it? You can turn on your iPod, you can pamper yourself, you can read. So 10 minutes is a long time. So if you're able to win 10 minutes, it's half of my lecture. It's a long time. So 10 minutes is great if you can win that. 10 minutes is a long time. Could you start the video, please?
Knowing the future when it comes to making a decision would be pretty handy for anybody. But there are professions where such a skill could mean the difference between life and death. These men are 3 of the best pilots in America. They are graduates of the US Navy's legendary Top Gun program. Lieutenants Snodgrass, Khmer, and Appizato were so good, they stayed on as instructors. What makes them so successful is their ability to make decisions, and more importantly, predictions, upside down, being crushed by gravity, traveling at the speed of sound.
It's a 3D dynamic environment, and they're constantly changing over time, so you have to be very, I guess, quick with your thought process.
You've got to take into account your own aircraft's energy, your altitude, your attitude, how many knots you have on the jet, how fast you're going.
055, 4 miles.
You've got to take all that in relation to your opponent or the threat. And oh, by the way, it's all happening at 300, 400, 500 knots.
Check left. Center left.
There are a lot of things to consider in a dogfight.
The Top Gun pilots are at the top of their tree, but even at this level, some pilots are consistently better. Better at anticipation and better in combat.
It does make you wonder why some pilots are better able to grasp spatial concepts better than others, but I think most people would just chalk it up to better spatial orientation, be a better ability to take concepts on board than other pilots.
The unexplained aptitude of the few is difficult to clearly define, but its effect is borne out by hard data. In every armed conflict since World War I, just 4% of fighter pilots have accounted for 40% of total kills. These super pilots reportedly have uncannily accurate powers of anticipation. The military call this exceptional situational awareness. But it might be that some pilots are simply able to exploit the precognitive abilities that we, perhaps, might all possess.
Okay, we're not pilots, but situational awareness is a very important thing during stressful working situations. I want you to look at this picture. Hans, what do you see? Stress. Sorry, what do you see?
Someone gasping for air.
Okay. Hans, other Hans, what do you see? What's your first thought?
Effort.
Okay, we can see stress, we can see danger, we can see hypoxia, we can see fear, just in time, out of danger, oxygen, relief. Is he going up or is he going down? This has to do with situational awareness. How do you look at the situation? How do you check what is true? So situational awareness during complex airway management cases is of paramount importance. It is defined as the perception of our environmental elements within volume of time and space. So you see a man in a swimming pool. The comprehension of their meaning, you may comprehend that he may be drowning, and the projection of their status in the future. You may project in the future that if you don't do anything, he will drown. It's a big difference. If you walk your dog and walk beside a swimming pool, you can say, okay, I see a man in a swimming pool in distress, he may be drowning, and if I don't act quickly, he may die soon. Or I see a man and he's swimming. So check what you're seeing, is situational awareness. Another point, team effort. We've heard about that already. Speak up when you work as a team. Appoint a team leader. And team leader roles may shift during a case. Verbalize your thoughts and never assume anything. And as already talked before, firemen, policemen, doctors have different backgrounds. We have different backgrounds in the hospital. We see different things. We see patients with different eyes. As a D physician, intensivist, or an anesthetist, we see different things. Look at another picture. Never assume anything. I see clearly only dolphins. I don't know what you are seeing. This is Amsterdam. But I only see dolphins. So if you think you see something, share your thoughts with the team. Are you also seeing dolphins or something different? Verbalize your thoughts. Then, how do we transfer the experience and expertise of the few into the clinical practice of all? Are there any airway guidelines or are there any protocols at the moment? The answer is, unfortunately not. And think about Amsterdam. If you read an airway protocol or have to use a guideline, this is our flag, 3 crosses. The current guidelines for airway management are not good enough. So we have a problem. We need very experienced airway managers. If you picture expertise, how do we get his expertise into the younger people? I think if you have to sail through a storm like in a Volvo Ocean race, or have to perform a front of neck surgical airway during an airway crisis, you can only do this if you start young. You need to train from the beginning. And we need to train paramedics, junior residents, colleagues, intensivists, emergency physicians. And in that way, we can transfer expertise which is present in the older and wiser people into the next generation. This is very important during airway management. And we should train as a team. We've been organizing already for 10 years advanced airway training sessions with simulation, with debriefing and with mannequins. This works really fine because you can train crisis. One of the last points, if you think about intubation, think about Escher, but also think about alternatives. Is ECMO an option? Can you resuscitate with a laryngeal mask airway? Or maybe high flow nasal oxygen? The answer is not always a tube. So in summary, to conclude my lecture, are we going to intubate in the emergency room? Use a stepwise approach. Use your team. Think about situational awareness. Prevent complications. And yes, this nice little chap, old chap, has made very nice drawings. But think and look twice before you intubate. This patient really needs a tube in the emergency room. Depends on the team, depends on the situation. And if you like airway management, like I do, please come back to Amsterdam in November this year. We will organize the World Airway Management Meeting in the Beurs van Berlage. It's a 4-day symposium. So I would like to invite you to come back to Amsterdam. Thanks.